The problem is that the traditional narrative in sort of the EMS space and the way that I experience it is that the connection that we have with other people is not always a positive one. It's usually a judgmental or a you're not good enough or I'm a better paramedic or sort of competitive rather than collaborative. And I refuse to act like that. So for me, it's about building connection with the person in the space that you find them to figure out what they need and what you need from them.
Hi everyone, warm welcome to everyone to the ParaPodcast team. I'm Tulani, and with me today is the usual suspects, Melusi Mtetwa and Elias Thomas, and together we make up the ParaPodcast team. Before we introduce our incredible guest, I wanted to get a little bit of insight from Melusi and Elias. And I'm just curious, I know I'm throwing a spanner in the works, but I'm just curious, in the EMS profession, who are some of the individuals that you look up to or who truly inspire you and why? And I'll tell you the reason why after you've answered me.
That Qatar internet connection.
Qatar internet. Always. You might have to do the question again at some point.
Yeah, I think I got the question, and I think it's who do you look up to in the EMS world? And why? Oh, that's a very difficult one. I think I had mentors back then, but obviously as you change, I think someone that I've looked up to was Fenki and Andret. Andret was one of the people that I think she wrote on pain management, and she's also part of the guidelines, the South African guidelines that are written now. And I think it's just her journey in EMS and where she's been and what she's striving for, trying to improve. And I think also just the dedication that she has put out to make the education in Namibia a little bit different. And I think one of the things that I like about her is that when she came to Namibia University of Science and Technology, she tried changing the culture of the military approach to sort of like academic focus. We're trying to produce clinicians that are really good in research, that are sound. I think it had an impact on my career because I think I was just floating. When she came around, that's when I started understanding things a little bit. So I think, that's one of the few.
And look at how you came out. Look at you.
True. Absolutely true. Yeah. I think with the military style, I was going to be out of the EMS by now, but yeah.
You're lazy. All right. Right. It's two people that I've thought of. It's good that I got time to think while Elias was talking. The first one, I think, like the primary introduction was, I'd say, shoes. There was a paramedic that used to work in Central.
Sounds like a weekend warrior.
Look. He was a chill guy. He was a CCA, critical care assistant at the time, and he was so chill. Like all the cases, he had the same way of treating them, and also treated students as people that came to learn. So that was during the work integrated learning. So I liked his style of working. He was so chilled. I think I incorporated that too in my practice. It also worked well too with my personality that I'm just chilled. I'm one of those people, they say above you are looking chilled and then underneath you're pedaling very fast like a duck. So I do that sometimes depending on the type of a case. But most of the time it's my superpower that I'm always chilled in most things. So it helps me a lot. Then the second one will be, I'll say Ravin Naidu. Ravin Naidu, he was HOD at the time at DUT. I think as a student, just looking at him, he was doing a whole lot of stuff. He was doing research there, and he was a HOD. He was involved in the HPCSA. I think now he's the director of EMS in South Africa. I'm not sure whether he still does that or not. But it was really fascinating to see a person who was just in that space and everyone actually respected in the department, And he would question things, making sure that you are doing... if there's something that people wanted to implement in the department, there used to be a requirement that has to be science-based. You can't just say you're implementing it because you think that it's going to work. There must be science that is backing it up. So he was good at it. And he was very much involved in implementation of thrombolysis in the pre-hospital setting. I know that it's not a skill that we practice a lot in South Africa, but I remember that in order for it to be added in the guidelines, he was somehow involved in that. And I think I was actually thinking about him. Was it yesterday or today that he was somehow? I saw him being referenced at American Heart Association, one of the guidelines there. I was like, that guy really did well. He really pushed hard. I think he ended up with 2 master's degrees or something like that, and he is working in the sector as a director of EMS. So those are 2 people. So basically, both academic and operations. Those are people that I really looked up to.
Okay, thanks for that, guys. Seems like even our guest knows shoes because he started smiling. But so just to talk about me is that I obviously have a lot of people that inspire me, but the one person that I want to talk about is our guest today. I've looked up to him mainly because of the person that he is. He is smart, and I think one of the things that I like is that he's smart but also humble. You don't feel that he doesn't show that he's smart. It doesn't. He's very humble, but also the guest that we have today is that when I met him, I was at Netcare in an education space. So now when you talk about him, you sort of always have to associate him with education and teaching. That's where he comes. That's what he's passionate about, and we'll talk more about that. But also, if you had to Google Kaleb Lachenicht, I hope I pronounced it correctly, is that you'd see that he's always presenting, he's always talking. The pictures that you see online on Google, it shows him talking or presenting something. But yeah, without wasting further time, is that Kaleb, can you please introduce yourself to our guests, to our viewers out there? Who is Kaleb? Can you tell us more about who is Kaleb? Where are you from? And yeah, the floor is to you.
Cool. So I'm Kaleb. I studied actually with Malusi in a DUT many years ago. And,
Legends.
yeah, he was one of my mentors.
Was I your mentor?
When I was in first year, so an unofficial mentor. Yeah.
Okay, I do remember you a little bit. I didn't think that it was that deep.
So I studied at DUT and then moved back to Joburg. That's where I love to be. I mean, I don't love to be here, but it's one of the things that you have to, one of the places you have to be if you want to get some stuff done in South Africa. And then I started my career in an AK911 space, spent quite a bit of time on the road, worked the Far East Rand and the sort of Springs Brakpan area. And then sort of moved into an ICU environment, which I really enjoyed. Really enjoyed the sort of really sick patients and transferring patients that were maybe not optimized for transfer. And then somehow got myself engaged in the education space. It is something that I had always kind of kicked against. Both my parents were teachers, neither of them in the emergency spaces, but both of them in primary and high school spaces. And I was adamant I was not going to be a teacher. Look at me now. I'm just...
it's in the blood.
Say again?
I'm saying it's in the blood. You can't run away from it.
You can't hide from it. I ended up teaching on the CCA program for the last 4 years that the CCA program ran at the Netcare FECC, and thoroughly enjoyed my time there. I really connected with some amazing practitioners, some other teachers, learned a lot, learned more, I think, by teaching than the 4 years that I spent on the road before I went to go and teach. And I think I learned a lot from the students, really engaged with how to get information across in a way that actually means something, and to change practice rather than to just fill heads with information. And from there, I went for a few years and worked in a private education space for a doctor's practice, one of the bigger practices in the country, running the emergency training for all the doctors around the country. And there again, I just learned so much just in terms of setting up a business, how to run a business, how to manage people, and how to engage with people very much outside of your comfort zones. And now I'm very lucky to be working and managing in the Rocket Hem space. It's probably the best environment I've ever worked in. But at the same time, also heading up the training division of Epic EM, where we get to build our own education space, and we kind of get to create the experience that we want for our students and have our students leave with a really cool experience. So that's kind of me in a nutshell.
Wow.
Okay. Can we end the interview already?
Let's say, it's impressive.
Can I say something? There's something that you do, Caleb. I was listening to you presenting the case. Was it the patient that was a chest pain or something that you did on the online thing that you do?
Yes, on coffee and cases.
There's a way you're also doing it now. I can't put a finger on it exactly. You have a way of explaining things. You've got the command that you have, but it's also gentle at the same time, and it's very clear. You don't confuse what you're saying. You know exactly what this person is saying, and it just sounds like, yeah, this person is on it. You know, you want to listen more and more and more and more and more. I guess that's where you found your niche and you became an educator, because that's what you do. That's what you need as an educator. It's pretty good. Yeah, kudos to you for choosing education training.
We speak about it a lot in the education space. There are scripts that we use a lot. So like some of the things that sound really polished and really good are just having been done like every day for the last 10 years. So a lot of the stuff is scripted. I'm actually finding the conversation fairly difficult because there isn't a script for the conversation, if that makes sense. Like explaining the clinical stuff is really easy because there are like set outcomes and you know exactly where you want the student to go to. But having a conversation that is unscripted, I'm actually finding it fairly challenging. So it's cool that you're finding it.
No, you're pretty good. And now that you mentioned the script, I remember when I used to teach BAA, there used to be a book that we used to have. It was a thick book. I used to know where do you find what, and I'll start this side. I'll ask tricky questions, knowing that I'll say on page 15, this is where you find the answer to that, you know. And everyone will think, "God damn, that guy is smart," you know. He knows the book inside out. Yet I know exactly where I'm taking the student. So I appreciate that. Yeah.
Now,
That is amazing.
Just to backtrack a little bit, Caleb, when you did your undergrad at DUT, I'm glad we have someone else come from DUT because it shows that
it's always me.
But how was your experience as an undergraduate student at DUT?
I really enjoyed my time at Durban University. It was exactly what I wanted to be doing. So it aligned directly with my sort of outcomes. I had a very fixed mindset in terms of I'm here to study for 3 years to get the most that I possibly can out of the experience and to work really as hard as I possibly could. I didn't have much of a personal life for those 3 years. But the experience of the education was absolutely incredible. We were taught by probably some of the best paramedics that I've ever had the opportunity to be engaged with. At the time that I was at DUT was very, very similar to the time that Lucia was there, and we had Ravine as our head of department. We were taught by the likes of the two Pillets. I think just in terms of the exposure to the number of CCAs that we had in our classes, attending with us, but then also taking us on road pracs on the weekends and in the evenings. I thoroughly enjoyed it. I wouldn't change it for anything.
Okay. And just to add, I think one of the pillars that you talk about,
it's the internet. It's the Qatar internet.
He said
just goes on a break for a few seconds.
Pretty good.
Is it there? Hello.
You're back now.
What? Yeah. Sorry, guys. I'm not sure what's happening. But one of the lectures, probably that lectured you is BC Pile. He saw a photo of me and you on Facebook. He's like, "Oh, you with Caleb in this interview?" I'm like, "Yes." And he said that Caleb was one of the good students that they've ever had. And tell us, what do you think about the rescue and
I think he says that to everyone. He said that to me too. When I saw him in the World Cup, he said that to me too. So I'm not trying to take your shine, Caleb.
Let the guy get his flowers.
And
he's just a good teacher, honestly.
Try to share the shine.
I know this is a bit controversial stuff that we've recently been talking about on the podcast. What do you think about the rescue and fitness requirements of the program?
Why you want to put me on the spot so early in the interview?
Don't worry, just your thoughts. Don't worry. This is not of your employer.
I know your answer now. I know your answer from that statement.
I think it's very important to be physically fit, right? And I think that there are definite requirements in terms of how a practitioner should not just present themselves to the world, but should present themselves in terms of a health advocate. So to have a 400 kilogram paramedic arrive to your side to treat you is probably not the picture of health. Yeah. Is there a medial like ground? I definitely think so. So in our rocket space, what we've started doing is implementing some physical requirements, but not necessarily a pass-fail, more a self-improvement program to try and get everyone to the fittest, most healthy version of themselves so that they can, first of all, do the job for as long as possible, but also avoid injuries. And obviously in the workplace environment, injuries and workman's compensation are quite a big thing. So the fitter somebody is, the better it is for the company, but also the better it is for the person. Should there be pass-fail requirements on a physical? I don't believe that should really be the case. Should it be a big part of the program, and should it be pushed as something that's important for mental health and physical health and longevity? 100%. Should it only be focused on the things that we do all the time? Probably not. I definitely think there's some space for sort of the yoga and the stretching vibes, a little bit of the meditation stuff, which I think would probably be just as important as a 5 or 10K run. I think we have some work to do still.
Love it. 5 or 10K run.
Yeah, that's us. We do that.
It depends where you went, right? When I was at DUT, we didn't have to swim. I feel sorry for all the swimmers out there. The people.
I refuse to comment, but and
having said that, I do wish that I did the swimming too, because that's one thing that I'm lacking for my triathlon. Like I can swim, but I don't think I'm a strong swimmer. So like right now I'll be doing triathlons because I cycle, I run, but now the swimming is shaky. So
same. I'm so scared of drowning. That's the only reason I won't do a triathlon.
Stay safe.
Swimming.
Well, Lucy, I think you should take over.
Yeah, continue.
Yeah, you keep cutting in and out.
I'm not sure.
You're back again.
Okay. So
yeah, you're 100%.
When I met Kaleb, at NECA FECC. But also we met somewhere on the road when we were treating patients. What I want to ask you is, what initially drew you to paramedicine, specifically to NECA 911? Is it because it was easy to get employment there, or there was specific reasons that drew you to initially paramedicine at NECA 911? And during your time at NECA, what were some of your most experiences during your time on the road?
So I'm not sure. I think it was probably that I had some friends and some acquaintances in the 911 space. I also did my BAA initially in 2005 through Netcare. And they offered me a really good post before I qualified, so I couldn't really say no. The East Rand was very short of paramedics at the time. And sort of 7 months before I qualified, they offered me an AEA post for the remaining 5 months or 6 months of my studies, and then a guaranteed post when I completed. They also offered me a spot in an area that I knew wasn't going to be saturated with ALS, and so I knew I would get some really cool experience, and I knew that I would have some really good challenges. It was also, at the time, a very well-supported system, I think set up for the new practitioner with quite a lot of assistance and sort of, I think the depth of practitioner in South Africa at the time was probably a little bit better. At the moment, I think there's a lot of newly qualified paramedics and then some really old paramedics, and that group in the middle seem to be where you guys are. Definitely not in the country anymore. And that, at the time, I was looking for a little bit of mentorship. I was looking for some good support, and it met all those boxes, and they were willing to pay me. So it was a win-win in all directions. In terms of my experiences at 911, I think at the time the system was also set up for medicine that didn't feel super financial. it felt like I could treat any patient that I came across, and I didn't have any challenges in having to defend why I had treated a patient in a certain way. And a large percentage of the patients that we ended up treating on the East Rand were definitely not medical aid patients. And that really aligned with what my beliefs were at the time, and just in terms of at the same time now, but I mean, access to treating patients in different spaces is a bit challenging now in South Africa. It aligned with my goals. It aligned with what I wanted to do and how I wanted to learn. So it was really good. I'd probably say my best experiences though were at the college on the road with students. The way that the college car was set up was very much like a provincial service, in that there was absolutely no requirement to make any profit, which was really, really great in a private service. So we had the best of the equipment, we had the best of the support, but at the same time, we were able to chase and treat every patient that we could possibly find for our students. So my 5 years at the college, I think just in terms of experience, I think I was set up best. So I was maybe a little bit more knowledgeable and had stopped making the mistakes that you make when you first qualify. I had the benefit of working with some students that I could first oversee, but also learn from their mistakes and help them learn from their mistakes. And also just the support at the time was just incredible. So some of the very best cases that I got to treat were working from that college car, the Tango 2 car. And I struggle to actually remember cases prior to the college. I don't know if they've just been blocked out because they were so
Too
horrific.
many.
Probably
Oh,
not.
I thought it's just too many. But yeah, sorry, I just wanted to cut you off a little bit there.
No, go for
Um,
it.
Yeah, and I just wanted to kind of get your experience since you work remote and you said you had the support in terms of mentorship. And when you went to work on the college, how would you compare the two in terms of how you guided your students compared to how you were guided into like developing as a paramedic? Because I think my experience from Namibia is that there was no mentorship. First of all, we didn't have enough ALSs to mentor you. And I think second of all, when you did your shifts at the hospitals, there was no one to oversee to ensure that you're actually learning to be competent in the skills, or they just sign you off sometimes. Oh, I did this, no, I witnessed it, but can you really do it? How did you find it? And, just if you can share a little bit of your experience on that.
I think I was quite lucky in that the environment I went to work in had a fair number of well-experienced providers. And although it was sort of the old days of you get dropped into it, so my first 3 or 4 shifts, I definitely worked with somebody to kind of learn the ropes and figure out the system. My base manager at the time was a guy, I'm sure you guys all know, Ronnie De Beer, who was just he was quite good at connecting, and he was very good at being present, even maybe not physically, but definitely via phone if I needed assistance or if I needed to connect with somebody. I was also quite lucky in that at the time that I qualified, there was quite a big group that were hired into the East Rand. And so there were 3 or 4 of us who were relatively new, handing over to each other and sharing experiences, and then often working together on handover shifts. So that was, although it's not a senior mentor, it's sort of a peer mentor, that it created the kind of support that I think I needed at the time. I didn't realize how flawed that system was of sort of the blind leading the blind until I went to the college and then had some quite senior mentors in the college space, not just in the education space, but also in the clinical space. So people who've been working for 10 or 15 years already, meeting the likes and working under the likes of David Stanton, with Fraka Rosley at the time. Getting to just really engage with well-experienced practitioners who are now at the point in their lives where they were looking for a bit more stability, but also looking to pass on their education knowledge and experiences as well as their road knowledge and experiences. And at the time when I started working at the college, there was this push to stay clinical. So you would go and teach, but you would also need to keep your skills up to date, and you would need to make sure that you were able to do all the things that you wanted the students to do. And I think it was a really magical time for me at the Netcare College. There was definitely a vibe of how do we grow, how do we learn together, how do we create the kind of environment that a student can really learn in, how do we develop the curriculum that makes sense for a student. And despite the flaws of the CCA course, I think we were given pretty free rein to create the kind of course that I think we all wished that we had when we were juniors. But also to create the kind of mentorship and support. So, I mean, I'm still in contact with probably around 80% of the students that I taught over those 4 years, because we created this culture of sort of a relationship of mentorship, where there's nothing that the student can come to you with that they can't speak about. There's no mistake or error that we can't have a conversation about and see how we can fix. There's nothing that I can't share in terms of my errors and the ways that I messed up when I was younger, and continue to mess up, because there are things that I learn I don't know every single day. And that, I think that exposure at that period of my career, and realizing that there were some things where education could have been done better, where it's not just about getting information across. It's really about creating the practitioner that you want to be, and how to help somebody be that. How do you practically do that? I think you create really safe spaces by being a very reflective and open practitioner, and by openly sharing your experiences with the student, not just the good stuff, but also sharing your mess ups and the places where you've grown and learned. I think sharing experiences of burnout are really important for the junior provider, because otherwise they think it's just something that makes them weak and less than. Um, and I think the curriculum setup is honestly the way that you create the kind of environment that you get the student to really achieve the things that they need to achieve. We spent a lot of time in the 2015 period redesigning the CCA curriculum, knowing that CCA was going to finish or stop running in the next 2 or 3 years. But really not wanting our students to leave that college with a design of the curriculum that didn't meet the requirement for what they would need to practice as later. And so, yeah, I think those three things are sort of the most important things.
That's very detailed and a lot of points to pick from there. And yeah, no, thank you for sharing. Honestly, it's I hope one or two people that are listening can learn a thing or two, especially around, focusing towards who you're trying to produce and what type of clinician you're trying to produce, and just being open. And I think that's the conversation that is difficult at times, being open with your mess up so that people can learn from it, and allowing that space where people don't feel judged, to share if they were unable to or they failed at something, but just try and do better. And I remember it was a system that was very much promoted with London Ambulance Service, to say that we want to hear about your mess ups, not for us to scrutinize you, but for us to make sure that that mistake never happens again, for any other junior paramedic that's coming through the ranks.
For sure. I mean, I think it's one of those things, we speak about it all the time in our training environment, is that if you want the magic of the human in medicine, you have to take the mistakes that come with them, because the human being is creative and fallible. And you could put a robot into that space and you could use AI to make all these decisions, and you'd probably get it right about 80% of the time. But that 20% of the time where you really need an adaptable, adjustable, creative human being, if you're using AI or a robot to do those things, you miss the magic of medicine. You miss the humanity. You miss the connection. You miss the whole point of everything that we're doing. And if we're going to expect creativity and adaptability of our practitioners, we have to expect error. And if we can't speak about error, then we can't speak about the vast majority of the learning experiences that we're exposed to.
Good stuff.
Yeah. Okay. You're making me lose train of thought because I'm just listening to what you're saying. But
He's hypnotizing.
that's one of the things that you said, that you don't say I want to demand your attention, but the way you present yourself. And Kaleb, because the podcast has various viewers. You've got your BAAs, you've got your ILSs. And it's sort of, when you spoke about your journey, I didn't know that you were BAA. And how the decision for you to go study further, how difficult was it for you, or was it easy? And for someone who's listening, who's a BAA, to let them know that it's possible. You can't just remain a BAA. Obviously, there's other factors involved, but it's possible to move from being a BAA to becoming an emergency care practitioner.
Oh, it was such a different time when I studied. For me, it was fairly easy. I did my BAA when I was 18. I'd literally just turned 18. And I had some really good advice from the people who taught me on that BAA course, that I'm young. I was privileged in that my family could afford to assist me with student loans and to figure out how to get myself to a university space. I was also supported through that education space, at least for the first year. So it was available. So like, even if I hadn't gone and done my diploma initially, I think that I would have studied beyond that. But the world was set up for me, if that makes sense. It was a lot easier for me at that time, at my age, without the stresses of family and having to provide for a family, to go and study. I think that I'm very glad I listened to the advice of those people who told me, "You're young, go do it now, quickly, before you get stuck into life." But I don't think that the road is complete. So I think that we just have to figure it out. There's a lot of work to be done in the South African spaces to make space for our experienced BAAs and AEAs to build to the next level. I think probably for me, one of the biggest challenges in the way that we've set up our environment is that we have set up a skills-based scope and a skills-based limitation environment for our practitioners. So if you think about, the BAA thinks that they can only ever be a BAA because their scope will never change. And for them to go and do an AEA now is impossible, but for them to go and do an ECA or an ECT degree or diploma, it's really difficult, because it's a year of work, and who's going to support them, and how do I manage my family life, and how do I do all of those kinds of things. It is possible, but it is difficult. And I think we owe it to the BAAs and the AEAs to figure out how we do that better, because we have left a whole group of people behind. Never mind the CCAs who also sort of fit into those blocks. I think as soon as you start thinking of yourself outside of the skills, outside of the scope of practice, you may not be able to increase the scope with your hands, but there's nothing stopping any practitioner from increasing the scope with their brain. And learning is not something that should stop because your scope is not expandable. Learning is something that should continue regardless of your age. And I mean, all of you guys have studied further and are doing things beyond your initial degree or diploma. And it's easy to imagine once you've done that. Once you've done the initial degree or diploma, it's easy to imagine more. But I think there are a lot of barriers that we, as a country, but also as a system, we need to figure out. I don't know how we do that, and we need more voices saying it, and we need more voices coming up with plans for how we fix it. But it's fixable in other countries. It has to be fixable here.
You're talking about something that is very important, Kaleb. Very important, very key. And I think a lot of people, they tiptoe around it, and it's just somersault to another year. I think it somehow is destroying the industry, because you have BAAs that are there, and the ILSs and everyone that you've mentioned. Yes, they can't really transition to where they should go, like in terms of betterment of their skills. This brings me to this question. Do you think there is room for online education that supports these clinicians to moving towards better qualifications? The reason I'm asking that, we had this discussion before. In Australia, there's a lot of degrees, a lot of universities offer them here, and people study, and they have possibly 4 times a year where they have contact sessions, and they go and attend those skills, and then they go back. They are expected to do some clinical practice. My point is, do you think there is room for that? Is there a space? You're also in education. You should know more around that space. What do you think about online degree for paramedicine?
I definitely think it's something we should be figuring out how to do as fast as possible. I think that there are some groups who are doing that, but who are getting a lot of resistance from the traditional structures in the country to say, well, we can't do that because we've never imagined what that might look like. But we don't have to look very far to figure out how other places are doing it. I mean, the UK have sort of short learning-based modules that can upgrade your qualification. Australia does it incredibly well. I think it's first of all naive, but also a little bit backward to think that we can't improve people's stations through online education when we're doing it all over the world for everything else. It has to be doable.
Yeah. Sometimes I was thinking also last week, thinking about the podcast and stuff like that, that I should try and pitch a point that talks to this. If you think about the quality of work that you get in South Africa, if you were to compare extended care paramedic that you find here, or ICP, what they call it, intensive care paramedic that you find here. If they were to do that course in South Africa, I think there would be much benefit for them because they'll get to practice the skills that they'll have there. Because here in this state where I am in South Australia, paramedics don't RSI. No one does that. And paramedics don't carry a ventilator in the ambulance. It's only MESTA, the helicopter, that does that. And it's a different unit altogether. But if they were to come to South Africa and study their, we call it ECP, Emergency Care Practitioner in South Africa, and then they do that as we did our diploma, transition from diploma to that space, I think there'll be great benefits. And also, even universities will make money from that. It's international students, and they make money from that, and people will come for that period of time, they attend, and then they leave. But the issue is also the rescue part that just stops people saying, because you don't have rescue, you can't then progress. I think we are really stopping ourselves from a lot of progress as people that were actually ahead in a lot of things in terms of the academic space and actually formalizing our qualification. If you compare it to even America and Australia, the registration with the Professions Council in Australia, you'll be surprised, started 2018. And also in New Zealand. And it wasn't there before. Yes, in South Africa, I don't remember it, possibly 1989 or something like that, back in the day where the first people that registered. So we were ahead. We are ahead in certain things, but I do think that we need to catch up with the education space too.
I think that there's probably, the more we speak about it, the more I think we probably need to start splitting the way that we teach emergency medicine, or at least on the pre-hospital side, into different streams. Because at the moment we've got a medicine focused degree with a lot of rescue, but that's not everyone's interest, and that's also not what everyone's going to use. In fact, I can count on one hand the times that I've used rescue. I use it now in my daily life, but I had to relearn everything because by the time I came to Rocket and we started doing rescue with the helicopters this side, I'd forgotten everything. Like, it's not something that I keep in my brain. But I think that there is definitely capacity to start splitting or specializing into sort of the rescue stream, potentially the neonatal stream, and the critical care stream, or critical care transport stream. Because a lot of and then maybe even the primary care paramedic, because I think that's probably more what we need on the ground than the specialized skills of the critical care paramedic. It's helpless getting a patient on a vent if we can't even assist the patient to manage his wounds in his home, so that he doesn't have to go to hospital. So, yeah, I think there's a lot of work to be done, but I don't know that we've empowered the right groups of people to do the work. And I don't believe that a lot of work is being done. I believe a lot of things are being said, but not a lot of stuff is happening. And I don't know how you fix that. I can only see it from the outside, which means it's really easy to make negative comments about. But yeah, it doesn't feel like we're working in the right direction to end up getting the patient what the patient needs.
Yeah, no, I think we could possibly chat about this the whole day, because few ideas are just popping into my head. Because then I'm comparing. No, in all honesty, I compare how I, like you spend I spent 3 years at uni, and when you finish uni, you've never seen a mental health patient, at least, and then you head up to a different service, and then you see mental health patients. You don't know how to deal with these patients, but then you have a degree, you know how to RSI. But you can't reassure a 10-year-old that's crying. Are you
Everything?
Yeah, what clinician is this? So yeah, I guess you could speak about it, but there are few loopholes that you could feel. And I definitely think there should be tiers as to where you can sort of like specialize. I guess we can cap on some of the modules and then try and specialize, or try and take certain, I don't know, channels. But yeah, Tulani, over to you.
Interesting conversations, and I hope the listeners find them interesting.
Whenever he has to talk, just practices.
Wow.
Yeah.
Now, Kaleb,
while he's figuring out this internet, I was just gonna say as well, Kaleb, you mentioned something about clinicians progressing through the stages. And I think the other thing that I was gonna say is just that there is nothing wrong with someone just remaining a BAA, and we have people that leave or that join the EMS service, while they are 40, 50s, and, they just literally all they want to do is just that patient to help the community. And I think we should normalize that, certain people just come in for that specific skill. And we should not look at them to say that, you are an under-resourced or like under-trained practitioner, but, as a valuable team member, in actual fact, I think at least.
I think what's really important, though, is that practitioner should be able to make that decision and should not be forced into that decision. So at the moment, you may have people who want to be a BAA forever, and that's absolutely acceptable. But you also have people who have absolutely no pathway to do anything else, and that is unacceptable. So rather the choice to say this is what I want or don't want, than being forced by the circumstance into that choice.
I'd rather have it than not have it. Yeah, no, definitely. Yeah, I agree.
So now, Kaleb, I'm back. But anyway, guys, Kaleb, we want to talk about, I think, something that's close to your heart, Epic EM. And what motivated you to launch Epic EM? And basically, for someone that doesn't know, and because I know what Epic EM, and even in where I currently work, is that the conversations about people that when they go and visit South Africa, who are they going to be doing their postgraduate courses? And your name would pop up now and then, which shows that there is significant reach even in Qatar. When people want to come that side, they know who to reach out to. So for someone that is listening and doesn't know what is Epic EM, what is Epic EM, and what motivated you to start Epic EM?
So Epic EM is essentially a training academy of the usual ALS, ACLS, PALS, ITLS programs. And it was set up because my wife and I both have the skills, we both have the instructor experience, and we left a position of training full-time, but sort of working very hard for somebody else, and decided that we would rather spend that time working very hard for ourselves. So we set up Epic EM with the sort of big picture of patient first. And every interaction that we create, we try and build the environment for safety and for good conversation, for really good learning experiences, and an experience that puts the patient at the center. It aligned at the time and still does with a lot of our beliefs. So in our previous employments, there was a big focus on finance and sort of making money, whereas we both felt that if the focus was on the right stuff, then that the financial backing would happen spontaneously. But the focus is on the patient and the focus is not on the students in seats, then things just work a little bit better. And so far that has worked fairly well for us. We've also created a whole lot of other programs, especially in places where we find gaps. So we've developed an airway management program, an 18-lead ECG assessment program, ABGs, ventilation programs, anything where there's a little bit of discomfort in the critical care environments. And that works not just for the pre-hospital, but also for the in-hospital spaces. And more recently have started getting involved in some hospital care spaces where we help hospitals figure out what their biggest problems are and then package solutions to try and fix those problems. So really easy examples, we have a client who has an adult ICU. They're not really able to transfer really sick patients out of their facility, but they also don't have staff that are qualified to treat peds necessarily as their primary. So there was a lot of discomfort around treating the pediatric ICU patient, even for short periods of time. And so one of our solutions is to put together then an ICU program for peds, and sort of take the staff through a program in their own unit, in situ simulation, using their equipment, their doctors, their resources to build capacity in the environment to treat the patient. So we really believe in bringing training to the person where they are. We'll go anywhere in the country. So we take our training to very rural spaces. We'll train. Often we've had to go and mop out sort of training rooms because there's water that leaked in from the roof the night before. We'll train any practitioner from the most basic to the most advanced. And we'll do it with the same level of passion and excitement around the patient. That's really what Epic EM is.
And in terms of this training that you did, how long is this training? Sorry, how long did you have to train this ICU team for?
So we put together a 10-week program, where we spend about 2 hours every week online doing some interactive case discussions and interactions. And then we spend a full day with 8 people in their unit working on their vents, their infusion pumps, their blood gases, just to make sure that they're really happy with their own equipment.
Okay. And at the end of this, do they get like a qualification? Do they get like a certificate to say, yes, you've completed this, these are the units you covered?
They do. So it's a little bit tricky in terms of there is no SACWA qualification that sort of aligns with any of these emergency medicine things. It all goes back to first AD kind of things. But we do a sort of a short course program with a certificate at the end of it. For us, it's less about the paperwork and much more about the experience and the provider at the end. So they do get a certificate, but the hospital is just also really happy with the way that they then interact from that point on, and that they have some kind of system for application. So it's also about finding the right clients. Obviously, if the client is looking to tick a box, then we're not the right provider.
Mm-hmm. I think I like what you said. Minister, do you want to say something? Okay.
Yeah, I was saying that I think I should plan. Planning to take some leave. I haven't told my employer this. I'm planning to take leave for like.
Got a way to find out.
between 3 and 6 months, sometime in the year or after, and then I need to come and do some course there with you. But it's for my studies. If I want to do my sampling in South Africa, that's what I'll have to do.
You can take me with you, Malusi.
And
one flight.
I'll put you in your bag. You're short.
Kaleb, I think you mentioned something about just ticking a box, and I think when it comes to postgraduate courses, people just want to tick boxes and also just to earn CPD points, whereas they lose the value of the meaningful learning and keeping up to date. The one question, and I'm going to phrase it in this way, is that some people say that your ACLSs, all these other courses are just a money-making scheme. And I'm sorry if I'm saying it like that. But on the other hand, is that people find value in keeping up to date because they keep current. And it's important for us as practitioners to keep current with the latest medical treatments for our patients. And one other thing that I keep hearing you mention is about patient safety, which is essential for patient safety. You said it before, that patient safety before everything else, not just to tick a box. So what are your views on that postgraduate learning for us, not just also for EMS providers, but also for doctors and nurses and any other healthcare provider?
So, I mean, the AHA courses were designed to make money. That is how they've been built, right? So every time we buy a book, we pay money to the AHA, and that allows the AHA to put some money into building what I think are fairly good educational programs to keep people up to date with regard to the latest in resus. Are those courses always very applicable in the third world? Probably not. But there aren't really alternatives. So it's about figuring out what really works in the South African space. So what we found in the rocket space is that ACLS is actually really important because those periods just before the cardiac arrest and mitigating cardiac arrest is basically our whole job, is trying to stop the patient from going into arrest. And then if they do arrest, it's managing that arrest. The ACLS and the PULS are really good evidence-based ways to keep people up to date. And the AHA have put a lot of time and effort into making the educational experience really worthwhile. Having said that, I think the better recommendation is to stay up to date in whatever it is that you have to be up to date in. So I know for our team, the vast majority of our interactions are around amazing pain management, very good ventilation, recognizing the septic shock patient, recognizing the bleeding and PPH patients. And we spend a lot of time, even when we do ACLS with our teams, speaking about those particular cases, because that's where you're going to make the biggest difference for my rocket team specifically. Mm-hmm. When we go to our Polokwane base with the rocket team, we spend a lot of time speaking about infants and neonates, because that's where they're seeing patients, the vast majority of their patients. I think what it comes down to is it's about the provider who's giving that training, tailoring that particular training to the group that they're going to be teaching. And if the student is there just to tick a box, they're going to have a terrible time working with Epic EM, because the expectation is that you're going to come to class and you're going to engage and you're going to get excited about emergency medicine again, and you're probably going to leave a little bit more passionate than when you arrived. And if that's not what you're looking for, then
The South African one came through.
Oh, there. Am I back?
Yeah, you're back. You're back.
You're back.
If the practitioner is only there to tick the box, they're gonna not enjoy the class very much. But if the practitioner has anything left in terms of excitement for emergency medicine, what we often find is that even the most boring ACLS on the planet, if you do it in the appropriate way and you hit that practitioner's hands, heart, and brain, you immediately reignite that excitement for emergency medicine. And they suddenly realize that it's not just about resuscitation. It's about patient safety. It's about the family's experience. It's about communicating with each other in a way that makes the best possible outcome. And they leave with the ACLS update, but they should also be leaving with some spark reignited for the excitement of medicine. Could we do these kind of update courses better? Definitely. Should we be doing them every 2 years? No. We should probably be doing something every 1 or 2 weeks over the period of 2 years to keep ourselves up to date. And that really comes down to how where you work manages how you interact. It's not good enough to just do something every 2 years and then expect to be up to date in any forum. I think if you haven't done an IO for 2 years, you're going to be anxious if you're going to need to do an IO suddenly today. But if you're practicing IO every 2 weeks, by the time it comes to having to do an IO or a surgical crack, you're going to be so comfortable with it, it's going to be the easiest thing on the planet. And I think that's kind of where we change things a little bit in terms of the education spaces. We're trying to expose people over and over again to this kind of drip learning thought process, the same thing over and over again in different forms, so that you really cement down that content. And that's where kind of Coffee and Cases comes from. We do a whole lot of simulation-based learning and discussion-based learning in the rocket space. And that's really where you see value. The once-off 2-day intervention doesn't change much.
Subscribe to Coffee and Cases. They're really good.
Yeah. It's free. You don't have to even subscribe. Just come.
Oh, yeah. It's free.
Do you mind telling our viewers about Coffee and Cases? Because I think it's a valuable platform that runs, I don't want to say much, but you can tell us more about the Coffee and Cases every Thursday.
Yeah, so actually Coffee and Cases started as an internal conversation with our rocket team, because what we realized was some of the team were seeing quite cool patients every week and others were seeing different patients every week, and we were never sharing the experience across the basis. So it started as 4 people around the boardroom table, just having a conversation and asking each other questions about this challenging case that was seen. And then it kind of morphed into a bigger group. Everyone in our team started joining on a regular basis. And then people just started asking if they could join. And now we run a group of around 2,200 people on a weekly basis, with about 300 to 400 participants now on a weekly basis. And I think the excitement around Coffee and Cases has been, and I don't know, as it's grown, it's been really difficult to maintain this, but creating the safe environment for good conversation, for the sharing of error. There's been a few Coffee and Cases where I've shared absolute mess ups from our side, where I think there was one patient that we just gave all the ketamine on the planet to by mistake in an infusion. There's been a few like really bad decisions that I've made personally, and having the platform to share it in quite a safe environment, but also to have the idea of a no blame culture, but not a no accountability culture. So to say, I made these errors and these are the ways in which I'm going to change my practice. Not, you're an idiot, you should be fired for what you've done, because we all make those mistakes.
Yeah.
That's kind of what Coffee and Cases is.
When you normally say this is a safe space, you can share whatever that you feel. I normally don't believe you, but now I believe you.
Amazing things shared on Coffee and Cases where you look back and you're like, but it's good. I think we need to have more of those conversations in this space.
Yeah.
Tulani, I just have one more that I just want to squeeze in there. Kaleb, just a little bit on Epic EM. How did you come up with the name? And also just perhaps to touch on a little bit on the collaboration side of things. I know you do training, you do upskilling. how can other organizations sort of like collaborate with you if they want to work with your company?
So we came up with the name actually when I was still at the Netcare College. We decided we wanted to run something that would be really exciting. So we did a sort of one-day conference, which was very immersive, very practical. We had some bleeding mannequins stuck around corners. We had some triage environments. It was very exciting. And at the time, I was watching Army Wives as a series, and they were speaking about, it's ridiculous, I know, but they were speaking about this idea of Army Strong, and I was like, what could be emergency medicine strong? But like it just sounds silly, and we actually came up with the idea of emergency medicine epic. So building this idea of something bigger than ourselves, something that is a value to subscribe to or to ascribe to. And the idea of EPIC kind of came across there. So we initially set it up as the FECC EPIC conference. And then it's just something that really stuck with me. And the way that we teach and the way that we engage sort of grew with me as I grew and became more and more that picture of something to aspire to be. And then when we were sitting around trying to figure out what are we going to call this new business, it was pretty obvious. It was just like, we have to call it EPIC. It's Epic Emergency Medicine. It's about building not just a brand, but a feeling and an experience. And yeah, I think that's kind of where the name came from. How do people collaborate with us? We have all of our details on our website. So www.epicem.co.za. And you can also just email info@epicem. And we're really keen to solve problems. So if you've got a problem in emergency medicine and education that you're looking to solve, we want to figure out how to fix it.
And it's easy
We haven't got all the answers
yet. It's easy to identify those problems. If people are don't doing the right thing, you know where to send them.
we're keen to figure it out.
Yeah. Sudan is still there.
Obviously, we're running out of time. Yes. Obviously, we're running out of time. I just want to ask you about something that is in your social media platform, LinkedIn. And it's probably something personal to you. And I think it's important that we talk about it, is that you mentioned your why focuses on creating environments that prioritize safety, clinical proficiency, and human connection. So for someone that is listening to this or that's going to go and read up on that, probably your LinkedIn will have a lot of views. But for someone that
definitely.
Can you elaborate on what this means in practice?
Yeah, so I think it's difficult to put words to something that you live, and I'm going to have to work a little hard to figure that out. There are three really important things for me as a practitioner, but also as a human being. So the first one is connection, and I think we'll chat a little bit about connection in our next little piece as well. But connection is what humans are about. We are social beings, and we require others in order to be the best versions of ourselves. The problem is that the traditional narrative in sort of the EMS space and the way that I experience it is that the connection that we have with other people is not always a positive one. It's usually a judgmental or a you're not good enough or I'm a better paramedic or sort of competitive rather than collaborative. And I refuse to act like that. So for me, it's about building connection with the person in the space that you find them to figure out what they need and what you need from them. The second thing is that if we're going to be what we need to be for patients, we need to be the best versions of ourselves. And so we need to, first of all, be clinically sharp, capable, practical. We need to be physically healthy, mentally healthy, and emotionally healthy in order to engage with our patients appropriately. And I see connection as sort of the centerpiece of all of those things. And I see the probably the fastest way, but also the scariest and most dangerous way to build connection is to show vulnerability. When you show vulnerability and you create that connection, obviously it first of all has to be vulnerability that is reasonable for the time and the experience and for the person. It can't be sort of fake vulnerability, and we can figure out what that means just now. But when another human shows you who they are, it is the closest way or the fastest way to connect. And the only way that you shut down that connection is to say, you're not good enough, I'm better. But if you come at that with empathy and you see things from another human's point of view, that vulnerability fosters incredible connection. And then I think the third thing that's really important to me is making sure that our patients are exposed to the safest possible environment that we can create for them. And sometimes, like, I know that today the environment is not as safe as it's going to be in 5 years' time, because I know that we're going to have learned a whole lot of stuff in the next 5 years. And then 5 years after that, it'll be more even safer. But we cannot create safe spaces for patients if we can't create safe spaces for practitioners. And we can't create safe spaces for practitioners if we can't be vulnerable and connect. And so for me, those things are all sort of tied up in one thing. And in order to create safe spaces for connection, in order for our practitioners to learn to create the best places for our patients, we have to be willing to be vulnerable, and we have to be willing to connect. And that's really challenging and really uncomfortable.
Wow. I think after what you said,
philosophy.
Yeah.
I think after what you said, Kaleb, is that there's nothing else that we can say. I think you've summed it up, because everything that we
Drop the mic and leave.
everything we've spoken about in this past 1 hour is that you've exposed your vulnerability, but also, I know Elias and Melus, we've exposed our vulnerability, but also things about patient safety, which is important. So it makes sense. And in closing, I just want to say thank you for your time. I know it's been difficult to try and arrange this podcast.
It's been difficult having an interview with you. That's what it's been.
But thank you for your time. And
South Africa is better than yours.
Yes. Anything else that Melus and Elias want to say?
No. We still have another segment coming up, so I think we can go fuel up, and then we'll catch you in the next segment.